All right, let's jump right in. I want you to think about the heart. It's the body's most important engine, right? It's this powerful, non-stop pump that keeps absolutely everything running. But what happens when that engine starts to sputter and fail? Today, we're going to break down congestive heart failure. And we're not going to look at it as just one single event. We're going to see it for what it really is, a dangerous and kind of fascinating chain reaction, a real domino effect, where the body's own attempts to save the day actually end up making things so much worse.
And that's the big question, isn't it? When this pump starts to lose power, it just can't move enough blood to meet all the body's needs, all those metabolic demands. And that creates a system-wide crisis, kicking off a cascade of consequences that ripple through the entire body. Getting this part is the key to understanding everything that happens to the patient.
So, let's get the official textbook definition out of the way. Congestive heart failure, or CHF. Now, this isn't the heart stopping. That's cardiac arrest. This is the heart becoming inefficient. The most important part of this whole definition is that phrase, to meet the metabolic demands of the body. The heart is still beating, absolutely, but it's just not strong enough to get the job done. It's a massive supply and demand problem.
Okay, so how does a muscle as powerful as the heart even get to this point? I mean, this doesn't just happen out of the blue. It's almost always the result of the heart being chronically overworked or damaged over a long period of time. So let's take a look at the main culprits, the big things that put this incredible strain on the heart.
You can pretty much lump the causes into four main buckets. First, you've got volume overload. Think of this like trying to force way too much water through a pump. You see this with things like intracardiac shunts, which are basically holes between the heart's chambers. Then there's pressure overload. This is like making that same pump work against a clogged pipe. A classic example is coarctation of the aorta, where the body's main artery is too narrow. Third is reduced myocardial contractility. This just means the heart muscle itself is weak and can't squeeze properly. This can come from cardiomyopathies, diseases of the heart muscle itself. And finally, high cardiac output demands, which is like redlining your car's engine for way too long. A body-wide infection like systemic sepsis can do this because the demand for blood flow is just massive. Eventually, the heart just gets worn out.
And here we are, the core of this whole domino effect. See, when the heart starts to fail, the body doesn't just take it lying down. Oh no, it launches a full-scale emergency response to try and fix the problem. But, and this is the big twist, these well-intentioned rescue missions, they actually become part of the problem itself.
And this, right here, is the absolute heart of the problem with CHF. The body senses that blood flow is low and it thinks, emergency, we need more volume, we need more pressure, let's go. But it's trying to solve the problem by whipping a horse that's already tired. These compensatory mechanisms just add more and more strain to an already failing heart, pushing it deeper and deeper into failure.
So let's look at the first domino. The weak heart pumps less blood out, while the kidneys notice this drop in blood flow and they hit the big red panic button. Their solution? They start holding on to all the salt and water they can to increase the total blood volume. They think, hey, more volume will fix the pressure. But all this extra fluid, what we call preload, just stretches that weak heart muscle out even more and forces it to work even harder to pump a bigger load. The fix literally becomes the problem.
And at the very same time, another domino is falling. The sympathetic nervous system, our fight-or-flight response, gets activated. It starts screaming at the heart to beat faster and harder. It also clamps down on blood vessels in the rest of the body to keep blood pressure up. But this clamping down, this vasoconstriction, increases what we call afterload. And that's like pinching the end of a garden hose. The pump now has to work against this incredible resistance, which just leads to more fatigue and more failure. Now, what's really interesting is that the symptoms you see depend entirely on which side of the heart is failing. So if the left side fails, it can't pump blood out to the body. So where does the traffic jam happen? It backs up into the lungs. Here's a great way to remember this. L is for left and L is for lungs. Now, if the right side fails, it can't pump blood effectively to the lungs, so the blood backs up into the rest of the body's venous system. This is what causes all that swelling in the liver, the spleen, and the periphery.
Okay, so we get the mechanics now. The weak pump, the fluid overload, the sympathetic nervous system going into overdrive, and the backup of traffic. But what does this actually look like in a real person? Let's take a look at how this whole chain reaction translates into the clinical signs and symptoms that we can actually see and measure.
See how all these signs connect right back to what we just talked about? Look at that first column, impaired myocardial function. That's the direct result of a weak pump. You get fatigue, a rapid heart rate, cool skin. The second column, pulmonary congestion, that's all about our left-sided failure. That's the rapid breathing and shortness of breath as fluid backs up into the lungs. And that third column, systemic venous congestion, those are the classic signs of right-sided failure. The edema, the weight gain, the enlarged liver, all from that body-wide fluid backup. Diagnosing CHF is kind of like being a detective. You start with the clues you gather from the patient's history and your physical exam, then you bring in the high-tech tools. A chest x-ray can show you if the heart muscle has gotten bigger, enlarged from all that overwork. An ECG can show the electrical signs of that muscle strain. But really, the gold standard is the echocardiogram because it gives you a direct, moving picture of the heart's structure and, most importantly, its function.
So we know the problem, we know the signs, we've confirmed the diagnosis. Now what? How do we intervene? How do we stop these dominoes from falling? Well, the goal is to break that vicious cycle we've been talking about and support the failing pump.
Our whole treatment plan, our whole playbook is built around these 5 clear goals. Number 1, we want to make the pump work better. Number 2, get rid of all that extra fluid that's overloading it. 3, reduce the overall work the heart has to do. And finally, make sure the body is getting enough oxygen as efficiently as possible. Every single thing we do is aimed at one or more of these targets. So, to improve that cardiac function, one of our go-to drugs is digoxin. It's an inotrope. That just means it helps the heart muscle squeeze harder and more efficiently, while also helping to slow down a heart that's racing. Now, for any nursing students out there, listen up, because this is the absolute non-negotiable key takeaway. You must always check the apical pulse before you give this drug. It has a very narrow safety margin, and patient safety is everything. All right, so how do we tackle that fluid overload domino? We use diuretics, like Lasix. These are really powerful drugs that basically tell the kidneys, hey, get rid of all this excess sodium and water, and that directly reduces the preload, the amount of fluid stretching the heart. The key nursing responsibilities here are super important. You have to meticulously monitor daily weights, their intake and output, and especially their potassium levels, because those can drop to dangerous lows. Beyond the meds, supportive care is absolutely crucial. We have to do everything we can to decrease the heart's workload. That means making sure they get rest, keeping the environment calm, and clustering our care activities so we're not constantly bothering them. Improving oxygenation with a little supplemental O2 and good nutrition is also key. And something as simple as positioning, placing the patient in what we call a semi-Fowler's position at about a 45-degree angle, that can dramatically ease the work of breathing, just by letting gravity help pull some of that fluid down in the lungs. And all of this brings us to our final thought. We've walked through the entire chain reaction, from the first problem to the body's flawed response, all the way to the signs in our interventions. So I want you to really think about this. If you want to stop a line of dominoes from falling, where's the best place to put your hand? Is it better to try and prop up that very first one? Or maybe pull one out from the middle of the line? Or do you just brace for the final impact? That right there, that's the strategic thinking that is at the very heart of managing CHF.